Welcome to Harrison Simplified session. Today we will discuss about approach to constipation. Constipation is a common complaint in clinical practice and usually refers to persistent, difficult, infrequent or seemingly incomplete defecation. So constipation is persistent, difficult, infrequent or seemingly incomplete defecation. Because of the wide range of normal bowel habits, constipation is difficult to define precisely. Most persons have at least 3 bowel movements per week. So most persons have at least 3 bowel movements per week. If the bowel movements frequency or stool frequency is low or normal frequency, but there is history of excessive straining, hard stool, lower abdominal fullness, or a sense of incomplete evacuation, then it is sole criteria for the diagnosis of constipation. So not only low stool frequency, that is less than 3 movements per week, rather it is also normal frequency with excessive straining, hard stool, lower abdominal fullness or a sense of incomplete evacuation. And there is two type of GI transit. One is slow transit, another is rapid transit. And this slow GI transit causes formation of hard platy stools and pellet like stool, hard plate like stools, and rapid transit causes loose watery stool. And you can judge this formation of stool by using Bristol stool chart. We used to classify various type of irritable bowel syndrome or IBS depending on Bristol stool chart. How is the consistency and shape of the stool? That is Bristol stool chart. And both small platy and very large stool is very difficult to expel than normal stool. So this is about the introduction of the constipation. Now we will know the causes of constipation. So causes, the main or principal cause of constipation is inadequate fiber or fluid intake. So fluid intake, decreased fluid intake is one of the main cause of constipation along with decreased fiber intake in diet. Then disorder colonic transit or anorectal function. So if there is any disordered colonic transit like slow transit or anorectal function dysfunction, that can cause constipation. Neurogastroenterologic disturbance, if there is any problem in the enteric nervous system function, neurogastroenterologic disturbance. Certain drugs, like I will discuss which drugs causes constipation. Then your advancing age or any association with large number of systemic disease can cause constipation. Constipation of recent onset may be symptom of significant organic disease of GI tract such as tumor, anorectal irritation or stricture. So this may cause acute type of symptom of recent onset. And some patient may have idiopathic constipation. This in this subset of idiopathic constipation, patient exhibits delayed emptying of ascending and transverse colon with propagation or prolongation of transit. So there is a delayed emptying of ascending and transverse colon with prolongation of transit, often in the proximal colon. And a reduced frequency of high amplitude propagated contraction or HAPC. So there is reduced HAPC or propulsive high amplitude propagated contraction in the GI tract that causes idiopathic constipation. And other causes include outlet obstruction to defecation, that is also known as evacuation disorder. So evacuation disorder causes outlet obstruction, accounts for almost 1/4 cases of constipation in tertiary care center, that causes delayed colonic transit, which is usually corrected by biofeedback retraining of the disordered colon. Then constipation may be caused or exacerbated by prolonged immobilization, hospitalization or by any chronic illness. So why hospitalization causes constipation tendency? Because there is physical or mental impairment along with inactivity or prolonged immobility. So all these factors together exacerbate the probability or possibility of constipation in hospitalized patient. Now we'll see the causes of constipation. So this table is taken from Harrison. So what are the causes of constipation? Number one, we will broadly divide into recent onset and chronic onset. Recent onset, if there is any colonic obstruction like your neoplasm, like colorectal carcinoma, stricture, anal stricture like ischemia, diverticulosis, inflammatory bowel disease, so that can cause colonic obstruction. Then your anal sphincter spasm, anal fissure, painful hemorrhoids can cause recent onset constipation. Even certain medication can cause constipation of recent onset. What are the common medication that causes constipation? That is iron tablet, another calcium supplements or calcium tablet, tricyclic antidepressant, and many other antipsychotics. Then your anticholinergic drug used for treatment of various maybe neurologic disorder or neuromuscular disorders. So tricyclic antidepressant, anticholinergic, your antipsychotic like phenytoin, carbamazepine. So this group of anticonvulsant drug. Then calcium channel blocker, especially verapamil. Then antacid. Then antispasmodic like mefenamic acid, dicyclomine, dotaverine can cause this type of symptoms like constipation. Now, chronic causes of constipation include irritable bowel syndrome, especially the variant constipation predominant, that is called IBS type C, irritable bowel syndrome type C. Another variant IBS M or mixed variety that can also have symptoms of both diarrhea and constipation. Next, your medication. I have already described what are the medication that may cause constipation tendency. Then colonic pseudo obstruction in case of slow transit like Hirschsprung disease, Chagas disease, disorders of rectal evacuation or evacuation disorder for pelvic floor dysfunction, anismus or anismus, descending perineum syndrome, rectal mucosal prolapse, and rectocele. So this causes evacuation disorder or problem in rectal evacuation. Then endocrinopathy, like very important hypothyroidism. Hypothyroidism causes constipation. Then hypercalcemia, pregnancy. Even hypokalemia, decreased potassium also cause constipation. Hypothyroidism, then your Sheehan syndrome or panhypopituitarism patient can also have features of constipation because of hypothyroid status. Some psychiatric disorder like your depression, eating disorder, drugs, neurologic disorder, Parkinson disease, multiple sclerosis, spinal cord injury, some type of stroke can cause. Then generalized muscle disease like progressive systemic sclerosis. Then sometimes diabetes mellitus, porphyria, diabetes mellitus. Then your autonomic neuropathy. Autonomic neuropathy can cause constipation. Amyloidosis itself or amyloidosis by autonomic neuropathy can cause constipation, amyloidosis. And sometimes from your knowledge of forensic medicine, you know there is some chronic poisoning with heavy metal like your mercury, lead, this type of poisoning with heavy metal can cause constipation. So these are the causes of constipation in adults. Now how to approach this constipation? First you have to take careful history because there are some important clinical clinchers about constipation. So you have to ask whether there is less than 3 bowel movements per week. So this favors constipation. Then type of stool, is it lumpy or hard? If there is any history of excessive straining, if there is history of prolonged defecation type, if there is need to support the perineum or digitate the anorectum to facilitate stool evacuation. To pass the hard stool, is there any need of digitate the anorectum? it is seen that in most of the cases, like more than 90% cases, there is no underlying cause of constipation. So this is very important. More than 90% cases, there is no underlying cause like cancer, depression, hypothyroidism. Constipation just responds to ample hydration. So you have to maintain your hydration properly, because less fluid intake can cause constipation. Even constipation in these cases responds to hydration, exercise, and dietary fiber supplementation. So these should be your primary approach to treat constipation, like hydration, exercise, and dietary fiber intake. And it should be in between 15 to 25 gram of dietary fibers per day. Then you have to ask about patient's diet, medication, and psychosocial issue, because medication and psychosocial issues can affect your bowel transit status. Then you have to do some physical examination. And what are the important examination? First is rectal examination. So you have to look for whether there any fecal impaction or not, and if there is any evacuation disorder related problem. So features suggestive of evacuation disorder is high anal sphincter tone, failure of perineal descent, paradoxical puborectalis muscle contraction, and puborectalis tenderness during straining to stimulate the stool evacuation. So these are the features of evacuation disorder. And you have to also examine whether there is any weight loss, rectal bleeding, anemia. So these are very red flag signs for with constipation, weight loss, anorectal bleeding. In this case, you have to evaluate the patient properly for any pathology that may be detrimental. So you have to do flexible sigmoidoscopy with barium enema or colonoscopy alone. So you have to go for either flexible sigmoidoscopy with barium enema or colonoscopy alone, particularly in patients with more than 40 years of age, to exclude any structural disease like cancer or strictures. Now, colonoscopy alone is most cost effective in this setting, because it provides an opportunity to biopsy the mucosal lesion. So you can do the biopsy, even polypectomy can be done. Even if there is any stricture, it can be dilated. So biopsy, polypectomy, stricture treatment by dilatation can be done during colonoscopy. So this is very cost effective, and this barium enema has advantages over colonoscopy in the patient with isolated constipation, because it is very less costly and identifies colonic dilatation and all significant mucosal lesion or strictures that are likely to present with constipation. Melanosis coli or pigmentation of the colon mucosa indicates use of anthraquinone laxative. So if the patient is using any type of anthraquinone laxative such as Cascara or Senna, so anthraquinone type of laxative such as Cascara and Senna, so this type of laxative abuse can cause pigmentation of colon, that is called melanosis coli. Okay, now you have to do some investigations for constipation, and investigation should be done: thyroid profile, TSH, free T3, T4, serum calcium level, because hypercalcemia causes constipation, potassium to look for any potassium deficiency, then colonic radiograph for disorders such as megacolon and athertic colon. Okay, cathartic colon. So these are the investigation. Now what will be the management of constipation? First you should encourage the patient for more dietary fiber intake. Then some bowel training regimen may be helpful. This bowel training regimen involves taking of osmotic laxative such as magnesium salt, lactulose, sorbitol, polyethylene glycol, and evacuating with either enema or suppository like glycerin or bisacodyl as needed. So after breakfast, a distraction-free period of 15 to 20 minutes on the toilet without any straining is usually encouraged in bowel training regimen. Excessive straining may lead to development of hemorrhoids, weakness of the pelvic floor, and injury to the perineal nerve. If there is no benefit from the above measures, or requiring long term treatment, then you have to go for further investigation. Otherwise, dietary fiber bowel training regimen is very useful. Now, what will be your algorithm of management for constipation? First, if any patient is coming to you with history of chronic constipation, then first you have to do certain clinical assessment as I have described, then laboratory test basic like thyroid, calcium, potassium, blood test, fasting blood sugar, then chest and abdominal x-ray, ultrasonography, and to exclude mechanical obstruction you have to do colonoscopy, very important for chronic constipation. So if there is report of normal colonic transit, then you have to consider this as a functional disease or functional bowel disease. So if the reports are within normal limit, if there is any abnormal report in colonic transit, I suppose slow colonic transit that causes constipation, if there is any known disorder, then you treat the disorder. If there is known in the disorder, even after this group of tests, so there is no known underlying disorder, then you have to do anorectal manometry and balloon expulsion test. If it is normal, then treat. If it is abnormal, then you have to go for rectoanal angle measurement and defecation proctography. Then appropriate management should be done like rehabilitation program, surgery, etc., especially for evacuation disorder or emptying disorder. So what are the investigations of severe constipation? Like, so severe constipation, these groups especially slow chronic transit, if there is no known disorder, no known disorder, so what are the tests to be done? So now we'll describe. So less than 5% patients presented with this type of severe or intractable constipation, and 25% of them is probably suffering from evacuation disorder. Now this evacuation disorder is measured by measuring colonic transit. Now how to measure colonic transit? The number one test is radio opaque marker transit test. These tests are very easy, repeatable, and generally safe, inexpensive, reliable, highly applicable in evaluating constipated patient in clinical practice. Now, what are the methods? For example, the radio opaque markers are first ingested, and abdominal flat radiograph film is taken after 5 days. So 5 days later, after intake of radio opaque some markers, you have to take a abdominal flat film. Then if there is any passage of the 80% marker, that is normal, and less than 80% marker out of colon without laxative or enema is actually normal. More than 80% without laxative, but less than 80% or support of laxative enemas is abnormal. Then another method is you can take 24 radio opaque markers on 3 consecutive days, and abdominal radiograph is taken on the 4th day. So the number of markers counted in the radiograph is an estimate for the colonic transit. So you patient ingested 24 radio opaque markers for 3 successive days, and you have to measure the number of abnormal abdominal radiograph on the 4th day. The number of markers counted is an estimate for the colonic transit. Usually the collection of gas in the rectum at the level of between ischial spine and lower border of sacroiliac joint, suggestive of rectal evacuation disorder as the cause of constipation. Now another test is radioscintigraphy with delayed release capsule containing radio level particles. So this has been used to non-invasively characterize normal, accelerated, or delayed colonic function over 24 to 48 hours with low radiation exposure. This approach simultaneously assesses gastric, small bowel transit because they reflect a more generalized GI motility disorder, and also colonic transit. So this is the advantage. This assesses small bowel, gastric, and also colonic transit. And disadvantage is it is very costly, and nuclear medicine lab help is required for this test. But in this case, like this radio opaque marker transit, these do not give any information about small bowel and stomach transit. This only gives informations about colonic transit. So small bowel, stomach for transit. The first test is not helpful, but radioscintigraphy is very helpful for gastric and small bowel transit. Now, anorectal and pelvic floor tests are there for pelvic floor dysfunction. Pelvic floor dysfunction usually suggested by inability to evacuate the rectum, feeling of persistent rectal fullness. There may be rectal pain. There may be need to extract stool from the rectum digitally, and application of pressure on the posterior wall of the vagina. There may be need of support of the perineum during straining, and there is history of excessive straining. So these histories are the suggestive of pelvic floor dysfunction. Now how will you measure this pelvic floor dysfunction and perineal descent? This perineal descent is relatively easy to measure clinically by placing the patient in left decubitus position. So we have to position the patient in left decubitus position and watching the perineum to detect inadequate descent. If there is less than 1.5 centimeter descent, this is sign of pelvic floor dysfunction. If there is perineal ballooning during straining or more than 4 centimeter descent and to bony landmarks, this is excessive perineal descent. Okay, so less than 1.5, this range is important in pelvic floor dysfunction. Then another test is there, that is simple clinical test in the office to document non-relaxing puborectalis muscle is to have the patient strain to expel the index finger during a digital rectal examination. The motion of the puborectalis muscle posteriorly during straining indicates proper coordination of the pelvic floor muscle, but the motion anteriorly with paradoxical contraction or limited perineal descent like less than 1.5 centimeter during simulated evacuation indicates pelvic floor dysfunction. Another test is balloon expulsion test. The overall test of evacuation is the balloon expulsion test. A balloon tipped urinary catheter is placed and it is inflated with 50 ml of water. So 50 ml of water is used to inflate the balloon tipped urinary catheter, and it is placed inside, and then normally a patient can expel it while seated on a toilet or in the left lateral decubitus position. In the lateral position, the weight needed to facilitate expulsion of the balloon is determined. Normally, the expulsion occurs with less than 200 gram added or unaided within 1 minute. Another test is anorectal manometry. So, this anorectal manometry, when used in evaluation of patients with severe constipation, may find excessively high resting anal sphincter tone, like more than 80 millimeter of mercury anal sphincter tone at resting condition, or squeeze anal sphincter tone suggestive of anal sphincter spasm, that is also known as anismus. So more than 80 millimeter mercury of pressure or anal sphincter tone measured by anorectal manometry suggestive of anal sphincter spasm, also known as anismus. Another test is defecography. This is dynamic barium enema test including lateral views obtained during barium expulsion. Either so this is dynamic barium enema test or a magnetic resonance defecogram. So these measure changes in the rectoanal angle, internal mucosal any prolapse, rectocele, enterocele, then your whole thickness, interoception, then your structure and function of pelvic floor, distal colorectal, anal sphincter is assessed by defecography. Another test is electromyography. This is neurological testing. Electromyography is more helpful in evaluation of patients with incontinence than those with symptoms of obstructed defecation. In the absence of neurologic sign in the lower extremity suggests that any documented denervation of puborectalis muscles, denervation of puborectalis muscles can be assessed due to injury or from stretching of pudendal nerve during chronic long-standing straining. Constipation is common among patients with spinal cord injury, neurologic disease like your Parkinson disease, multiple sclerosis, diabetic neuropathy, autonomic neuropathy. So this type of disease can be assessed by electromyography or neurologic testing. Then your spinal evoked responses during electrical rectal stimulation or stimulation of external anal sphincter contraction by applying magnetic stimulation over the lumbosacral cord identify patients with limited sacral neuropathies with sufficient residual nerve conduction to attempt biofeedback training. So this is all about the investigations for severe constipation. So your first is radio opaque marker transit test, second is radioscintigraphy, then pelvic floor dysfunction test, perineal descent assessment, balloon expulsion test, anorectal manometry, deficography, electromyography, and spinal evoked responses. Now how will you treat the constipation? First you have to ensure adequate hydration. So this is very important. This is the first point, adequate hydration. And you have to look for if there is any immobility. If there is any immobility, then you have to ensure proper mobilization and exercise. So this hydration, exercise is very important. Along with diet, you have to ensure proper intake of dietary fibers, bulk. So dietary fibers, high fiber intake, psyllium husk. Then your osmotic agents like milk of magnesia, lactulose, and polyethylene glycol. So this type of osmotic laxative can help. You can also give secretory agents like lubiprostone, linaclotide, plecanatide, tenapanor. So these are newer drugs for treatment of chronic constipation. So this lubiprostone is a chloride channel activator. So this is chloride channel activator, and this linaclotide is nothing but guanylate cyclase C agonist. This is guanylate cyclase C agonist. So this is the mechanism of lubiprostone, chloride channel activator, and linaclotide, guanylate cyclase C agonist, that activates chloride secretions used in treatment for constipation. So these are secretory laxative. Then your prokinetic agent you can use, or stimulant laxative like diphenyl methanes like bisacodyl or sodium picosulfate, or 5-HT4 agonist like prucalopride. This is prucalopride, tegaserod you can use. Then for pelvic floor dysfunction, you have to suggest for pelvic floor training, especially biofeedback and muscle relaxation. Then psychological counseling is very important, because more than 90% cases no cause found. So in these cases psychological training is very important. Then dietary advice you should give, like high fiber intake, adequate hydration. So for combined evacuation and transit or motility disorder, and for few cases surgery may be needed. For few cases surgery needed. So surgery is needed for pelvic floor dysfunction, maybe alone, or for motility disorder. For pelvic floor dysfunction, biofeedback training is helpful in 70 to 80% cases. Operation that can be done is internal anal sphincter or puborectalis muscle division and botulinum injection. So this can be done in case of pelvic floor dysfunction. And for transit and motility disorder, laparoscopic cholecystectomy with ileorectostomy can be done. But what is the complication of this colectomy with ileorectostomy? It causes small bowel obstruction in 11% cases, and sometimes fecal soiling, particularly at night, is one of the major complication of this surgery. Frequency of defecation is usually 3 to 8 per day following surgery in the first post-operative years, and from second post-operative years the frequency of defecation is 1 to 3 per day. So 1 to 3 episode per day of bowel transit or bowel frequency, 1 to 3 following second post-operative year. So this is all about approach to constipation. In the next video of simplified Harrison simplified session, we will discuss approach to diarrhea. So thank you very much for careful listening. Don't forget to subscribe my channel Dr. Shankar Dey for more videos of Harrison based discussion. Thank you.